The kidney. I think a lot of people, when they think about the kidney, they just see it as, a simple filter, something that just handles waste.
Right, but that's really just scratching the surface. It's so much more. It's a master regulator, a really sophisticated chemical processor.
It's balancing everything, isn't it? We're talking about fluid volume, acid-base balance, blood pressure, even things like bone health and making red blood cells.
Absolutely everything. And what's so fascinating and what our sources really dig into is how the kidney acts as this silent sensor of your body's overall health.
So it's not just about diseases that start in the kidney.
Exactly. We often focus on those primary kidney diseases, a structural failure in the filter. But just as many renal issues, and honestly, often the most aggressive ones, are really just reflections of systemic diseases. Things like lupus or uncontrolled diabetes or severe hypertension.
And that's our focus for this deep dive. We're getting into Chapter 20, the kidney, which is, I have to say, a dense but incredibly rewarding set of sources. Our mission here, especially for you, the learner, is to navigate the real complexities of renal pathology.
And we're not just doing summaries here.
No, we're going way beyond that. We're going to be breaking down the key diagrams from the text, analyzing the molecular pathways, and really zeroing in on the microscopic evidence. The pathology slides, that's the core of it.
Yes, the H&E, the electron microscopy, the immunofluorescence, focusing on that microscopic evidence is absolutely paramount. The kidney has such a vast functional reserve.
Meaning you can lose a lot of function before you even know it.
A tremendous amount. You can have a huge amount of damage occur silently before any clinical signs, like a drop in the GFR, even start to register. So we're going to structure this around the 4 key areas: glomerular diseases, tubulointerstitial diseases, vascular diseases, and then finally, renal neoplasms.
And the cost of failure here. I mean, it's not a small issue affecting a few people. The cost, both human and economic, is just staggering.
Oh, it's far from it. The source material really emphasizes this enormous burden. End-stage renal disease, ESRD, which is when you need dialysis or a transplant, that affects over 660,000 Americans.
And the cost is something like, what, $72 billion a year?
Annually, just for maintenance treatments. And that's not even counting chronic kidney disease, CKD, which affects something like 1 in 9 adults in the U.S. It often progresses silently, which is why understanding the pathology, seeing that progression on the slides, is so central to fighting this immense disease burden.
Okay, so before we dive into the microscope, we need that clinical context. We have to speak the language of kidney trouble, right?
Yep.
We need to define the major syndromes.
Right. These are the clinical flags that tell us where in the kidney to even start looking for the problem.
So let's start with the basics. Azotemia.
Azotemia is the biochemical sign. It's purely a lab value. It means you have elevated blood urea nitrogen, BUN, and creatinine in the blood. It's the first chemical signal that your GFR, your filtration rate, is down.
And when that biochemical failure starts to affect the whole person, that's uremia.
That's uremia. Uremia is the collection of clinical signs and symptoms that come with severe, prolonged azotemia. This is where those retained toxins start causing havoc everywhere else.
Like outside the kidney.
Way outside. You get uremic pericarditis, which is inflammation around the heart, uremic gastroenteritis, problems with bleeding, and really profound systemic issues like peripheral neuropathy. Uremia is proof that the kidney's complex metabolic functions have failed, not just its waste disposal role.
And we also classify failure by how fast it happens, acute versus chronic.
Correct. Acute kidney injury, or AKI, is a rapid, sometimes catastrophic decline in GFR. We're talking hours or days. The good news is AKI is often reversible if you can fix the underlying cause quickly.
What are some of those common causes?
Things like ischemia, so a sudden drop in blood flow, exposure to toxins, or an acute obstruction like a kidney stone blocking things up.
And then there's the slow burn of chronic kidney disease.
Right. CKD is the opposite. It's an irreversible loss of function, progressing slowly over months or years. The strict definition is a GFR of less than 60 for 3 months or more. This is that slow, steady path that, for many patients, ends in end-stage renal disease.
Okay, now for what the sources call the Great Divide. This is really the foundational concept, isn't it? Nephritic versus nephrotic syndrome. This is the first question any pathologist is going to ask about a kidney biopsy.
It's absolutely crucial. This distinction immediately tells you about the type and the location of the injury in the glomerulus. They represent 2 fundamentally different ways the filter can fail.
So let's start with nephritic syndrome. What's the key word there?
Inflammation. Nephritic syndrome is defined by an active, destructive, inflammatory injury to the glomerular capillary wall.
And because that wall is being physically breached, physically torn apart by the inflammation,
You bleed. The clinical hallmark is hematuria, blood in the urine. And specifically, you see red blood cells and, even more importantly, red cell casts in the urine, which proves the bleeding is coming from the glomerulus itself.
And that inflammatory response messes with everything else, too.
Oh, yes. It leads to a reduced GFR, which causes oliguria, or low urine output, and azotemia. And you frequently get hypertension because of the volume overload and the renin system getting activated. There's some protein in the urine, but usually not the massive amounts we see in the other syndrome.
So we can think of nephritic as an acute inflammatory attack. It's bleeding, it's destruction, and it's retention of waste.
Exactly. Now you contrast that with nephrotic syndrome. Here, the defining feature isn't inflammation at all. It's a massive failure of the filter selectivity.
It's just leaking.
It's leaking profoundly. The hallmark is massive proteinuria. The definition is a loss of more than 3.5 grams of protein per day in an adult. The injury is typically non-inflammatory. It's about damaging the podocytes or the charge barrier, not causing a physical breach.
And that massive loss of protein is what drives that whole classic cascade of nephrotic symptoms.
It does. You're leaking tons of albumin into the urine. Albumin is the main protein that keeps fluid in our blood vessels. So you get hypoalbuminemia, low albumin in the blood.
And without that albumin,
the plasma osmotic pressure drops and fluid just leaks out of the capillaries into the tissues. That causes severe generalized edema. You see patients with swollen legs, puffy faces.
And the liver tries to compensate, right?
The liver goes into overdrive trying to make more albumin, but it also churns out all other proteins, including lipoproteins. That leads to the characteristic hyperlipidemia, high cholesterol, and then lipiduria, where you actually see fat in the urine.
So for you, the learner, this is the fundamental roadmap. If the clinical picture is nephritic bleeding, hypertension, the pathologist is hunting for inflammatory proliferative diseases.
And if the picture is nephrotic, massive protein leak, severe edema, they're looking for permeability defects, often something very specific to podocyte injury.
Okay, let's zoom in. This is where it gets really fascinating. The microscopic anatomy of that filter. When you visualize the glomerulus, it's this incredibly delicate three-part structure. It's designed for the most selective permeability in the entire body.
You really have to have a mental picture of that capillary wall. That barrier is everything. It has 3 main layers, and we can walk through them from the inside, from the blood, outwards.
So what's the very first layer the blood encounters?
That's the fenestrated endothelium. The cells lining the capillaries are just full of these little pores or fenestrae. They're big enough to let water and small solids pass through easily, but they hold back the blood cells and really large molecules.
Then you have layer 2, which is sort of the backbone of the whole thing.
That's the glomerular basement membrane, the GBM. It's this dense, complex matrix made of type VV collagen, laminin, and a really critical component: highly negatively charged proteoglycans, specifically heparan sulfate proteoglycan.
And that negative charge is key. But let's get to the third layer first, the most delicate one.
The third layer on the outside is the visceral epithelial cells, or as we call them, podocytes. These cells are incredible. They wrap around the capillaries and send out these long arms that branch into thousands of tiny interdigitating foot processes.
And the gaps between those foot processes are the filtration slits.
Correct. So you have this dual system. It's both a size sieve and a charge repellent.
Let's break that down. How does it keep a protein like albumin out of the urine?
Okay, first is size selectivity. The proteins that bridge those filtration slits between the foot processes, proteins like nephrin and podosin, they form what's called the slit diaphragm. That diaphragm is the physical sieve. It blocks molecules bigger than about 70 kilodaltons.
But albumin is actually smaller than that. So in theory, it could slip through. Why doesn't it?
And that is the crucial role of the charge barrier. The GBM and the podocytes themselves are covered in these powerful negative charges from the proteoglycans, since most plasma proteins, especially albumin, are also negatively charged.
It's like trying to push 2 same-sided magnets together.
Perfect analogy. There's a powerful electrostatic repulsion. That anionic repulsion is what keeps the vast majority of albumin in the blood. So loss of that negative charge is often the very first step in developing massive proteinuria, even before you can see any obvious structural damage.
So that structure immediately tells you what to look for pathologically. If you lose the charge, you leak protein, that's nephrotic. If you physically tear the whole thing apart, you leak cells, that's nephritic.
Precisely. Now, how does this delicate barrier get injured? The sources make it clear. Most injuries are immune-mediated, and we mostly focus on antibody-mediated damage.
And there are two main ways that immune complexes can cause that damage.
Right. It really all centers on where those immune complexes form and where they deposit. The first way is what we call antibodies binding in situ. This is when antibodies are directed against fixed antigens that are already part of the glomerulus.
Like the anti-GBM antibodies we'll talk about later.
Exactly. The antibody attacks the type 5e collagen of the basement membrane directly. But the more common scenario is circulating immune complex deposition.
So the complex forms in the blood first, then gets trapped in the kidney.
Correct. Antibodies bind to some circulating antigen, maybe it's DNA from a patient with lupus or an antigen from a strep infection, and they form these complexes in the blood. Then, just due to physical factors, size, charge, hemodynamics, they get trapped as they flow through the tiny glomerular capillaries. They can deposit in different locations, subendothelial, subepithelial, or in the mesangium.
But whether the complex forms in place or gets trapped there, the result is the same. It kicks off a massive inflammatory cascade.
Exactly. As soon as those immune complexes deposit, they rapidly activate the complement system. This leads to the formation of powerful inflammatory molecules like C3b and ultimately the C5-9 membrane attack complex, or MAC.
And that's the signal for the cavalry to arrive.
It is. The complement activation recruits neutrophils and macrophages, the leukocytes, which then release their own inflammatory mediators, growth factors, and destructive proteases. That whole inflammatory storm is what physically damages the capillary loops and causes the bleeding and the hypercellularity that we see in the nephritic syndromes.
All right, so let's apply that to some specific inflammatory injuries. We're talking about active destruction of the filter now.
Let's start with acute post-infectious glomerulonephritis. This is the absolute textbook example of an acute immune complex-mediated nephritic disease.
So what's the classic story? What makes a pathologist immediately think of this diagnosis?
It's the timeline. It classically follows an infection, usually a group A beta hemolytic strep infection, either strep throat or a skin infection like impetigo. The key is the delay. The patient gets sick, then they get better, and then 1 to 4 weeks later, they present with an acute nephritic syndrome.
And that latency period is the time it takes for the body to mount that immune response, form the complexes, and for them to deposit in the kidney.
Exactly. And while the presentation can be dramatic, hematuria, edema, mild hypertension, the prognosis, especially for children, is actually quite good. But the diagnosis is confirmed with that triple stain approach.
So let's look at the pathology. What does the H&E slide show?
When you look at the H&E, the glomerulus is just massively hypercellular. It's packed. You see what we call diffuse endocapillary proliferation, an explosion of mesangial and endothelial cells. And on top of that, extensive leukocytic infiltration. The capillary loops look swollen, congested, and almost bloodless because they're just so clogged with cells.
That proliferation is the direct response to that inflammatory storm. But how do you prove that immune complexes are the cause?
For that, we turn to immunofluorescence, or IF. The IF slide is diagnostic. It shows these beautiful granular deposits of IgG and C3 in both the glomerular basement membrane and the mesangium.
And this is the starry sky pattern.
That's the classic description. The staining is lumpy, it's coarse, it's discontinuous. It's the definitive visual proof that you're dealing with trapped circulating immune complexes.
And then finally, you use electron microscopy, the EM, to confirm the exact location of those complexes.
The EM shows the characteristic location. They are discrete subepithelial electron-dense deposits. They accumulate just outside the GBM, right underneath the podocyte foot processes, and they are classically described as humps because of their dome-like shape. We think the antigen is a strep protein, maybe SPEB, and the body's antibodies form complexes with it. Those humps on EM, plus the granular IF and the hypercellular LM that completes the diagnosis.
Okay, now we move to a much more severe condition, rapidly progressive glomerulonephritis, or RPGN. This isn't just a severe disease, it's a clinical emergency. Function collapses in weeks or months.
RPGN is a sign of extreme destructive inflammation. If it's not treated, it leads to irreversible renal failure very, very quickly. And pathologically, it's defined by a single terrifying feature: the crescent.
Describe the crescent. What is it, and what does it do to the glomerulus?
A crescent forms when the GBM is so badly damaged that things that should be inside the blood, especially fibrin, leak out into Bowman's space. That fibrin is a powerful stimulant. It triggers the rapid proliferation of the parietal epithelial cells that line Bowman's capsule.
So the lining of the capsule itself starts to grow.
It grows into this crescent-shaped mass of cells mixed with fibrin and infiltrating macrophages. And this crescent physically expands and completely obliterates the urinary space. It essentially smothers and crushes the functional capillary tuft inside.
And the sources classify RPGN into 3 types based on immunology, which is critical because the treatment is completely different for each.
Right. Type I RPGN is the anti-GBM antibody disease. This is a very specific in situ reaction where the body makes autoantibodies against the type IV collagen in the GBM. The diagnostic finding on IF is a smooth, continuous, linear deposit of IgG and C3 all along the GBM.
And this is what we see in Goodpasture syndrome.
Exactly. In Goodpasture, those same antibodies often attack the basement membranes in the lungs, causing life-threatening lung hemorrhage along with the kidney failure.
Okay, what's type 2?
Type 2 is the immune complex RPGN. This is defined by a granular IF pattern, which tells you that you're dealing with trapped circulating immune complexes. It's basically RPGN that arises from another underlying disease, like a really severe case of post-infectious GN or advanced lupus or an aggressive IgA nephropathy.
And then there's type 3, the pouchy immune form. It's defined by what you don't see, but it's incredibly destructive.
It is. Pouchy means few. So this is the pouchy immune form characterized by having little or no immune deposits on IF or EM. This type is very strongly associated with systemic small vessel vasculitis, specifically ANCA-associated vasculitis.
Wait, hold on. If there are no immune complexes deposited, what is causing the damage? How is the kidney being so rapidly destroyed?
That's the critical distinction. In pouchy immune disease, the damage isn't from deposited complexes. It's thought to be mediated by the ANCA antibodies directly activating circulating neutrophils.
So the damage is happening in real time in the blood vessels.
Exactly. The ANCAs cause the neutrophils to degranulate and just dump their destructive enzymes and reactive oxygen species right onto the endothelium of the glomerular capillaries. The damage is acute, it's overwhelming, it's highly inflammatory, but the mechanism leaves almost no trace of the immune trigger on the pathology slide. Understanding that ANCA mechanism is key because you have to treat the systemic vasculitis to save the kidney.
All right, let's shift gears completely. We're moving away from that inflammatory, bleeding-based nephritic picture and into the hyperpermeable, leakage-based nephrotic picture. The kidney is leaking vital proteins.
And we'll start with minimal change disease, or MCD. It's a fascinating paradox. Clinically, the patient, who is usually a young child, is incredibly sick. They have dramatic, massive edema and huge amounts of protein in their urine. But pathologically...
It's called minimal change for a reason.
For a very good reason. It's the most common cause of nephrotic syndrome in children, and it has this classic dramatic response to steroids. But what's vital for the learner is the microscopic definition. On light microscopy, your standard H&E stain, the glomeruli, look completely normal.
No proliferation, no inflammation, no scarring.
Nothing. And on immunofluorescence, it's negative, no immune deposits.
So if the H&E and the IF are both normal, how on earth does a pathologist confirm the diagnosis? How do they explain this massive clinical syndrome?
They have to go to the highest magnification we have, the electron microscope. The EM is the only definitive tool here. It reveals the key structural defect, which is diffuse effacement of the podocyte foot processes.
What does effacement mean in this context?
It means they're flattened. Those long, delicate, interdigitating foot processes just flatten out and merge together. The filtration slits are eliminated. The ultrafilter collapses. This effacement, which is probably caused by a T-cell cytokine that also strips away the negative charge, leads directly to that massive protein leak. It is a purely submicroscopic lesion causing a macro-level failure.
Okay, now to membranous nephropathy, or MN. This is a leading cause of nephrotic syndrome in adults, and it has a very different, very distinct appearance on the microscope.
MN is essentially a chronic in situ immune complex disease, and it's localized to the subepithelial space. While it can be secondary to things like drugs or lupus, the primary idiopathic form has just revolutionized our understanding of kidney pathology.
And that revolution was the discovery of this specific autoantibody target.
Exactly. We now know that primary MN is strongly linked to autoantibodies against the PLA2R antigen. That's a receptor that's expressed right on the surface of the podocyte. So the antibodies bind to it right there, in situ, forming the immune complexes in that subepithelial space. It went from being an idiopathic disease to a defined, targeted autoimmune disorder.
So let's look at the morphology that results from this chronic deposition.
On light microscopy, the H&E shows a diffuse, uniform thickening of the glomerular capillary wall. But this isn't from cells proliferating, it's from material being deposited.
And the IF confirms the immune component.
Right. The IF shows granular IgG and C3 staining all along the capillary loops. But the really defining feature comes from the silver stain and the EM.
What do you see there?
The EM shows these irregular electron-dense deposits that are wedged between the GBM and the epithelial cells, subepithelial. And crucially, as the GBM tries to react to these deposits, it starts to synthesize new membrane material that bulges around the complexes. This creates the highly characteristic spikes that you can see protruding from the GBM on a silver stain. Over time, the GBM eventually envelops the deposits, making the membrane incredibly thick and irregular.
Okay, next up is focal segmental glomerulosclerosis, FSGS. This is a major cause of nephrotic syndrome globally, often with a much poorer prognosis than MCD.
And the name is a perfect microscopic definition. Focal means only some of the glomeruli in the biopsy are affected, and segmental means that even in the affected ones, only parts of the glomerulus are scarred or sclerosed.
And this isn't one single disease, it's a whole category.
It's very heterogeneous. At its core, it's a disease of severe podocyte injury that leads to cell death and then scarring. You have primary idiopathic forms, you have secondary forms from things that overwork the kidney, and you have very specific genetic forms with mutations in those key slit diaphragm proteins like nephrin and podocin.
But the initial injury is the same as MCD, right? The effacement of the foot process.
Absolutely. The effacement is the common pathway of podocyte stress. But in FSGS, the injury is just so severe or so sustained that the podocytes actually die. And when they die and detach from the GBM, that part of the capillary loop collapses and scars down.
So what does the light microscopy show that tells you it's not MCD?
In the affected segment of the glomerulus, you see that collapse of the capillary loops. You see an accumulation of hyaline material and fibrosis, and often that scarred segment will stick to Bowman's capsule, forming an adhesion.
And there's a particularly nasty variant, the collapsing variant.
Yes, the collapsing variant is very aggressive, often seen with HIV-associated nephropathy. Here, the entire glomerular tuft looks like it's retracted or collapsed, and you see this massive hypertrophy and proliferation of the visceral epithelial cells, the podocytes, which fill up Bowman's space. Seeing that on a slide is a marker of very, very rapid renal failure.
Let's address a key question for the learner. Both MCD and FSGS show foot process effacement on EM. How does the pathologist or the clinician tell them apart? How do you know if a patient has the steroid-responsive MCD or the often steroid-resistant FSGS?
That is one of the most challenging dilemmas in all of nephrology. Clinically, a rapid response to steroids is a good sign it's MCD. Pathologically, it comes down to sampling. Because FSGS is focal, if the pathologist gets a biopsy sample and doesn't happen to find one of the scarred segments, they have to call it MCD.
So it's possible to miss it.
It is. If they find even one single scarred segment, the diagnosis is FSGS. So the prognosis can depend on the quality and size of the biopsy. This is also why genetic testing for those nephrin and podocin mutations is becoming so essential for any child who doesn't respond to steroids. It helps clarify the diagnosis.
Okay, let's keep going, connecting these glomerular diseases back to systemic issues. Next up is membranoproliferative glomerulonephritis, or MPGN.
Right, MPGN is really a classification based on a shared morphological pattern. You see both mesangial proliferation and GBM thickening, and clinically it often presents with a mix of nephritic and nephrotic features.
Let's focus on type I, the immune complex form, and its really recognizable feature on the light microscope.
In type I MPGN, the immune complexes deposit in the subendothelial space, that's between the endothelium and the GBM. This deposition triggers proliferation of the mesangial and endothelial cells. And the mesangial cells react by sending their own cellular processes into the capillary loop, trying to lay down a new layer of basement membrane.
And it's that cellular interposition that creates the classic pattern.
It creates a duplication of the GBM, or what we famously call the tram track appearance when you use special stains like PAS or silver. The capillary wall looks like it's split into two parallel tracks because that mesangial cell has squeezed itself in between. Seeing that is pathognomonic for type I MPGN.
Now, type 2, which is now often called dense deposit disease or C3 glomerulopathy, is one of the most fascinating complement disorders we've discussed.
It really is. It's a profound failure of complement regulation. It's associated with chronic, relentless activation of the alternative complement pathway.
And what's the specific molecular driver behind that relentless activation?
Often it's an autoantibody called C3 nephritic factor, or C3nef. This antibody binds to the alternative pathway's C3 convertase enzyme and stabilizes it. Normally, that enzyme is highly unstable and gets shut down quickly, but C3nef acts like a molecular glue, keeping it switched on.
So the brakes in the complement system fail.
The brakes are gone. This leads to uncontrolled, persistent cleavage of C3 and massive deposition of complement byproducts in the kidney. And the EM finding confirms this unique internal assault.
Where are the deposits?
The EM shows this highly dense, ribbon-like material that is laid down within the GBM itself, intramembranous deposits. This location is unique, and this relentless attack often leads to a very rapid progression to end-stage renal disease.
All right, let's move on to IgA nephropathy, or Berger disease. The sources note this as the most common cause of recurrent hematuria worldwide.
Yes, and it's a perfect example of how a systemic abnormality in an antibody can localize destructive complexes specifically to one place, the kidney's mesangium. IgA nephropathy is characterized by IgA containing immune complexes deposited primarily in that mesangial region.
And the current thinking is a multi-hit mechanism.
Right. The first hit seems to be a genetic or acquired problem with the IgA molecule itself, specifically abnormal glycosylation or sugar attachments on the IgA1 hinge region. This abnormal IgA is then seen as foreign by the body, which triggers the second hit, the production of autoantibodies against it, forming these large immune complexes.
What's the classic clinical presentation?
It's recurrent episodes of gross or microscopic hematuria that happen at the same time as, or very shortly after, a respiratory or a GI infection. We call this synpharyngitic hematuria, and it's different from post-strep, where the hematuria happens weeks later.
And what do the pathology slides show to confirm the diagnosis?
On the light microscope, you see focal or diffuse mesangial proliferation. The mesangium just looks swollen and expanded. But the immunofluorescence is the diagnostic gold standard. It shows clear, granular mesangial deposition of IgA and usually C3. No other primary glomerular disease has this hallmark mesangial IgA predominance.
And the clinical course is notoriously variable for such a common disease.
It is. It can range from being totally benign with just hematuria for decades to a slow but progressive decline. About 15 to 40% of patients will eventually progress to end-stage renal disease over a couple of decades, which really underscores why early diagnosis and monitoring are so important.
Okay, we have spent a lot of time on the filter. Now we need to move downstream into the plumbing, the tubules, and the surrounding interstitium. These diseases often present as acute kidney injury.
And we'll start with the most common cause of AKI in hospitalized patients, acute tubular injury, or ATI. This is, by definition, the destruction of the tubular epithelial cells.
The source material splits the causes into two big buckets, ischemia and toxic injury.
Right. Ischemia is simply the result of a severe reduction in blood flow, hypoperfusion from shock, hemorrhage, severe dehydration. The tubules, especially the proximal convoluted tubules and the thick ascending limb of the loop of Henle, are incredibly metabolically active, and they're in zones of the kidney that naturally have low oxygen tension, so they are extremely vulnerable to ischemia.
And the second category is direct toxic insults.
Toxic injury is direct damage to the cells. It can be from endogenous things like myoglobin released during a massive muscle breakdown or hemoglobin from hemolysis. Or it can be from exogenous agents like certain antibiotics, some chemotherapies, or heavy metals.
So explain how the injury to these cells actually leads to acute kidney failure. It's more than just the cells dying.
It's a multi-pronged mechanism. First, obviously, the injured cells don't function well, but second, as the cells die and slough off, they form these intratubular casts plugs of debris that physically obstruct the flow of filtrate.
So you get a blockage.
A blockage. And third, and this is critical, the damage compromises the tubular basement membrane, so the filtrate that has been formed can actually leak back out into the interstitium. We call that backflow. The combination of obstruction and backflow is what causes the GFR to plummet in AKI.
What do you see on the H&E slide in ATI?
You see the morphology of cell necrosis. Ischemic ATI is often patchy, with skipped areas of injury. Toxic ATI tends to be more diffuse. In both cases, the key finding is the presence of hyaline, pigmented, and granular casts inside the tubules. The good news here, though, is that tubular cells have an amazing capacity to regenerate. If you can remove the underlying insult, the kidney can often recover.
Okay, let's move to infection. Pyelonephritis. This is a kidney infection, usually from bacteria ascending from the lower urinary tract.
And the vast majority of cases are caused by bacteria, most commonly E. coli, coming up from the bladder. The key risk factors are anything that causes urine to sit still or flow backwards, things like a urinary tract obstruction or vesicretal reflux, VUR.
Let's define acute pyelonephritis on the H&E slide.
Acute pyelo is a hallmark of infection. You see a patchy, suppurative, or pus-forming interstitial inflammation. The histology shows the tubules and the interstitium are just flooded with a dense, acute neutrophilic exudate. You see microabscesses forming within the tubules. Crucially, the glomeruli are usually spared, which helps you differentiate it from a glomerular disease.
And a really severe complication here is papillary necrosis.
Yes, that's an ischemic and infectious catastrophe. You see it most often in diabetics or people with severe obstructions. The very tips of the renal pyramids undergo coagulative necrosis. It's a very serious complication.
And when you get repeated bouts of this, it leads to chronic pyelonephritis.
Right. Chronic pyelo is the end-stage scarring from repeated infections. Grossly, the kidney is shrunken and has these coarse, discrete corticomedullary scars on the surface, which correspond to blunted or dilated calyces underneath.
And what's the key microscopic finding that tells you this chronic scarring is from pyelonephritis and not something else?
The pathognomonic finding is thyroidization. Because of the chronic damage and atrophy, some tubules become massively dilated and get packed full of this thick, pink, amorphous protein material. And they look strikingly similar to thyroid follicles filled with colloid. That unique morphology is the microscopic signature of chronic pyelonephritis.
Okay, but the tubules can also be the target of an immune response, not just an infection. Let's talk about acute drug-induced interstitial nephritis.
This is most frequently caused by very common drugs antibiotics like penicillins, NSAIDs, proton pump inhibitors.
What's the mechanism here?
It's a hypersensitivity reaction, usually a type I or type 5. It develops anywhere from a couple of days to over a month after starting the drug. And the clinical presentation is a very classic triad: fever, rash, and peripheral eosinophilia.
And what does the pathology slide show that points to this hypersensitivity?
The H&E shows a prominent, dense, interstitial infiltrate of mononuclear cells, lymphocytes, plasma cells. But the critical diagnostic clue is the presence of numerous eosinophils mixed in. Finding eosinophils in the kidney interstitium is highly suggestive of a drug-induced hypersensitivity reaction. And again, the glomeruli are generally spared.
Let's move to the blood vessels. The kidney gets about 20% of the cardiac output. It's absolutely dependent on its vascular supply. So problems there, from hypertension to microclots, are incredibly destructive.
We'll start with nephrosclerosis. That's the term for the pathological changes we see in the kidney from hypertension and aging. It's all about sclerosis and narrowing of the small arteries and arterioles, which leads to chronic ischemia.
And what are the two distinct vascular changes you see microscopically?
With chronic benign hypertension, you get hyaline arteriolosclerosis. This is where you see a pink amorphous material hyaline deposited in the walls of the arterioles, which thickens the wall and narrows the lumen.
And in more severe malignant hypertension.
There you see hyperplastic arteriolosclerosis. This is a concentric, laminated layering of smooth muscle cells in the vessel wall. It's often described as onion skinning because of the multiple layers. This severely narrows the lumen and can lead to fibrinoid necrosis of the vessel wall.
And the end result of all this vascular narrowing is just patchy ischemic damage throughout the kidney.
Exactly. Grossly, the kidneys get smaller and have this fine granular surface from all the little areas of cortical atrophy. And when you have malignant hypertension, that severe arteriolar damage can lead to rapid renal failure and microangiopathic hemolytic anemia, which leads us right into the thrombotic microangiopathies.
Right. Thrombotic microangiopathy, or TMA. This is a whole spectrum of disorders where you get microvascular thrombi leading to that triad of hemolytic anemia, low platelets, and acute renal failure.
The key mechanism across all TMAs is endothelial injury. Something injures the lining of the small blood vessels, which triggers inappropriate and excessive platelet activation and aggregation. You form these microthrombi that clog the delicate renal microvasculature.
And that clogging consumes platelets and shreds the red blood cells that try to cast through.
Correct. That's what causes the characteristic fragmented red cells or schistocytes that you see in the blood.
Let's quickly run through the classic forms.
Typical hemolytic uremic syndrome, HUS, is usually Shiga toxin-mediated. It typically follows an infection with E. coli 0157.H7. The toxin gets absorbed from the gut, travels to the kidneys, and directly injures the endothelial cells there, kicking off the whole cascade.
Atypical HUS is different.
Atypical HUS, or AHUS, is often a genetic disease. It's linked to mutations in complement regulatory proteins, like factor H. This leads to uncontrolled complement activation right on the surface of the endothelial cells, causing injury from within. It's another failure of the immune system's braking mechanism.
And finally, thrombotic thrombocytopenic purpura, TTP.
TTP is caused by a severe deficiency of a specific enzyme, ADMTS13. The job of this enzyme is to cleave large multiswimmers of von Willebrand factor. Without it, these massive VWF multiswimmers accumulate and spontaneously cause massive platelet aggregation and widespread microthrombi.
And pathologically, what do all these TMAs look like under the microscope?
On the H&E, the defining feature is the presence of thrombi, filling the glomerular capillaries and arterioles. In severe cases, the massive ischemia can lead to diffuse cortical necrosis, where you can see large, pale areas of dead tissue across the renal cortex.
Okay, we're transitioning now from acquired injury to structural failure that's written in the genes congenital and cystic diseases.
Let's start with the most common one, autosomal dominant polycystic kidney disease, ADPKD. This is a major cause of ESRD in adults, responsible for up to 10% of cases.
And it's caused by mutations in the PKD1 or PKD2 genes. What do those genes do, and how does their failure lead to these massive cysts?
PKD1 and 2 encode for proteins called polycystin-1 and X2. These proteins are found in the primary cilia of the tubular cells, which act like little antennas. Polycystin-1 is a mechanosensor that detects fluid flow, and it couples with polycystin-2, which is a calcium channel. When they malfunction, the cells can't properly sense flow, which leads to abnormal proliferation and fluid secretion, and that forms the cysts.
And the morphology is just devastating to the kidney structure.
Absolutely. Grossly, the kidneys become enormous. They can weigh several kilograms each. And they're just replaced by hundreds or thousands of these massive fluid-filled cysts that compress and destroy all the normal kidney tissue. It also has systemic effects like liver cysts and life-threatening berry aneurysms in the brain.
And there's a much rarer childhood form, the recessive version.
Right. Autosomal recessive polycystic kidney disease, ARPKD. This is caused by a mutation in the PKHD1 gene. Morphologically, the kidneys are also enlarged, but the cysts are very different. They're small, they're uniform, and they originate exclusively from the collecting ducts, giving the kidney this characteristic spongy appearance. It's also severely associated with congenital hepatic fibrosis.
Let's touch on the medullary cystic diseases like nephronophthisis.
Nephronophthisis is the most common genetic cause of ESRD in children and adolescents. It's another one of these ciliopathies caused by mutations in genes that encode ciliary proteins.
And where's the pathology localized?
It causes chronic tubulointerstitial inflammation, but the distinctive finding is the presence of small cysts that are concentrated specifically at the corticomedullary junction. Clinically, these kids present with severe polyuria because the medullary damage impairs the kidney's ability to concentrate urine.
All right, our final section. Let's look at tumors of the kidney, focusing on the most important one, renal cell carcinoma, or RCC.
RCC isn't a single disease. It's really a family of tumors that are classified by their distinct histology and, importantly, their genetics. The major risk factors are what you'd expect: tobacco use, obesity, hypertension.
Let's go through the three main types, which are classified based on their genetics and histology.
The most common, at 70 to 80%, is clear cell RCC. This is strongly associated with the loss of function of the VHL tumor suppressor gene on chromosome 3p. Second is papillary RCC, about 10 to 15%. This is associated with trisomies of chromosomes 7 and 17, and often caused by activating mutations that emit proto-oncogene. And third is chromophobe RCC, about 5%, which is associated with multiple chromosomal losses and generally has the best prognosis.
Let's spend a moment on that VHL mechanism in clear cell RCC. It's really key to understanding the cancer's biology.
VHL normally acts to degrade a transcription factor called HIF, hypoxia-inducible factor. When the VHL gene is lost, HIF is constantly stable, even when there's plenty of oxygen. This stable HIF makes the cell think it's profoundly hypoxic, and it turns on this massive program of growth factors, especially VEGF, vascular endothelial growth factor.
This is the pseudo-hypoxia state.
Exactly, and it's what drives their rapid growth and the incredibly high vascularity that is so characteristic of clear cell carcinoma. And it's why VEGF inhibitors are a cornerstone of treatment.
So let's visualize the morphology. What do they look like, grossly?
Grossly, RCCs are typically large spherical masses. They're famously variegated and often have this bright yellow-orange color because of the huge amount of lipid and glycogen in the clear cells. A critical feature is their tendency to invade and grow as a tumor thrombus into the renal vein and sometimes all the way up into the inferior vena cava.
Okay, let's do a deep dive into the H&E slides for the three main types.
For clear cell RCC, the cells have this abundant, distinctively clear or vacuolated cytoplasm. That's from all the lipid and glycogen that washes out during processing. They're usually arranged in nests or cords with a very rich, delicate vascular network.
Papillary RCC.
That's structurally defined by forming papillae, these finger-like projections with a central fibrovascular core. You often see foamy macrophages in those cores.
And finally, chromophobe RCC.
These cells look very different. They have very distinct, prominent cell membranes and pale eosinophilic cytoplasm, sometimes with a clear halo around the nucleus. They're usually arranged in solid sheets. The fact that these three types look different, have different genetics, and different prognoses is why the pathologist's ability to tell them apart is so absolutely critical.
The depth of this dive has been just substantial. We've gone from the tiny filtration slits of the glomerulus through the inflamed starry sky patterns to the destructive crescents of RPGN. We've detailed scarring from hypertension and infection and classified the three major genetically distinct kidney cancers. It just shows how interconnected our systemic health is with the kidney's integrity.
And the sources really hammer home a fundamental principle for any learner in this field. Renal pathology often requires a triple stain diagnosis. You absolutely cannot differentiate these key diseases without all three pieces of microscopic information.
Let's synthesize that one last time. Why do you need all three?
First, you need light microscopy, the H&E, to see the overall structure. Is there hypercellularity? Is there scarring? Are there patterns like tram tracks or thyroidization? Second, you need immunofluorescence. What's the immune driver? Is the staining linear, like an anti-GBM disease, or is it granular for immune complexes? Where are the deposits? And third, you need electron microscopy.
The tiebreaker.
It is the tiebreaker. It confirms the precise location of deposits, the humps versus the dense ribbons. And crucially, it's the only way to see the submicroscopic lesions, like the podocyte foot process effacement in MCD and FSGS, which are completely invisible on the light microscope.
Without that three-pronged approach, you simply can't tell the difference between these diseases, and therefore you can't determine the right treatment or prognosis.
Exactly. For you, the learner, the key takeaways are these. First, that nephritic versus nephrotic distinction is your starting line. It tells you if you're looking for an inflammatory breach or a permeability failure. And second, many of the most destructive diseases, RPGN, TMA, dense deposit disease, are fundamentally disorders of uncontrolled immune or complement activation.
And ultimately, no matter the cause, the structural consequence of chronic damage, the scarring, the glomerulosclerosis, is just this irreversible countdown to ESRD.
It is. The high functional reserve of the kidney means that by the time a patient is symptomatic, a huge amount of structural damage has already been done.
That reality is sobering. But the emergence of molecular pathology offers some hope. We've seen how we can trace clear cell RCC back to a single gene, VHL, or primary membranous, back to a single autoantibody, PLA2R. Given that we're moving from just describing what a disease looks like to identifying its exact molecular cause, what new individualized therapeutic paths might open up in the next decade based on this microscopic molecular level of understanding?
That is the future. The future of nephrology is moving upstream, finding that specific gene or protein defect that started the whole process. The era of just treating the symptoms is ending. The ability to precisely tailor a therapy based on a patient's PLA2R level or a specific podocyte gene mutation, that is the revolution that's going to define kidney care in the coming decades.